Good afternoon. Is Dr. Comencini here? Oh, great.
This is our fifth presentation today.
Today? Congratulations.
She has another one, I think.
All right. Is it okay if we get going because it's a pretty tight afternoon?
Yeah, sure.
All right, thank you.
Hi, everyone. My name is Maria. Thank you for the opportunity to present our work. This is a retrospective analysis of octogenarian patients undergoing off-pump versus on-pump CABG, and we'll discuss in-hospital outcomes, 30-day mortality, and long-term survival. As a quick introduction, with increasing life expectancy, the number of octogenarians undergoing CABG has grown significantly. However, this population poses unique challenges due to high risk and high frailty. So we wanted to look at our experience and analyze the outcomes in this specific patient's population. We utilized propensity score matching, and we did univariate and multivariate Cox regression to find predictors of long-term mortality. The numbers, as you would expect, would be small. We started off with 711 patients. Most of the patients, around 55%, underwent off-pump CABG. After propensity score matching, we had 245% in each group. They were adjusted for all the covariates, and we were left with well-balanced groups. In terms of in-hospital outcomes and 30-day mortality, we did not find any significant differences in these outcomes. When we looked at our long-term survival, off-pump did show a survival advantage over on-pump. However, this was not statistically significant. When we examined predictors of long-term mortality in octogenarian patients, we found out that age was associated with long-term mortality. Additionally, previous cardiac surgery had a profound impact on long-term mortality with a hazard ratio of 68. And additionally, LV impairment was also a significant predictor of higher long-term mortality. At the same time, other comorbidities did not influence long-term mortality. So to conclude, our study showed that in-hospital outcomes and long-term survival in this specific population did not show any difference, and off-pump and on-pump, both approaches are safe in this subgroup population. Thank you.
Thank you. That was fantastic. Since we don't have a question from the audience, I'll kick you off. So since this is all your institution, right? Single institution. So as a retrospective study, presumably you have some algorithm for how you and the surgeons decide who's on and off pump. Can you share that with us?
In terms of the surgeons?
How do the surgeons decide whether the octogenarians are on or off pump at your institution?
Most of the patients go through a multidisciplinary discussion, and depending on, our off-pump surgeons, they would very rarely turn any patients down, so they would accept high-risk and low-risk patients, and and then the on-pump surgeons would do these procedures as they are available.
So it sounds that the decision to perform on or off pump is based on the surgeon.
Yes.
Okay.
Okay.
Thank you.
Thank you.
Thank you so much.
Okay, the next speaker is Dr. Torre. I'm quite they're interested in your presentation. Okay, please.
Thank you. Oh, sorry. Thank you for the opportunity to present our very early experience on early surgical closure without ventriculotomy of post-infarction ventricular septal defect. So, basically, going right to the technique, before the CPB institution and relying on echocardiography measuring, we prepare generally two large Teflon and two large patches made with two layers of Teflon and one pericardial layer with sutures together with the 5-0 Prolen running sutures. And normally the left patch should be bigger than the right patch. And we then place also two central Ethibond stitches on the left patch that we tie to a surgical loop. That's because, as we said, we don't use a left ventriculotomy, neither a right ventriculotomy, but we use more standard transversal aortotomy and the right atriotomy. So, using a right angle, from the right side, we pass across the ventricular septal defect and we grab the surgical loop I was mentioning before, and by pulling it out from the tricuspid extremity, we parachute down the left patch into the ventricular cavity, the left ventricular cavity. And we do the same with the right patch. So using a hollow needle, we pass the Ethibond stitches inside the right patch and we parachute it down into the right cavity, right ventricle cavity, and then we tie them together. And we don't need to completely occlude the ventricular septal defect because actually the intraventricular pressure will do that during the heart contraction. So this is our numbers. They are very tiny, but as known, like it is a quite rare complication. So 11 patients from 8 different hospital institutions. Vast majority of the patients had severe cardiogenic shock with intra-aortic balloon pump and ECMO support. And interestingly, 91% of the patient had an acute PDA occlusion with a posterior basal VSD, and the mean diameter was around 20 millimeters. So, 55% of the patient underwent urgent surgery in the first 48 hours from presentation, and we had almost very short CPB and cross-clamp times in isolate repair procedures. As you can see, and even if the surgeons has no experience with the technique. 30 days mortality was 45%, and we had almost no residual VSD in 91% cases. Only one patient had a residual VSD and underwent hybrid closure with an Amplatzer. About the follow-up, we had 5 months mean follow-up. The 6 survived patients are all still alive, and we still have no residual and recurrent shunt, and almost all of them are in this NIA 1 class. Finally, about the conclusion, the technique seems to be feasible, simple, and with good short-term results. It achieves a complete occlusion without ventriculotomy, and almost all type of VSD can be addressed, especially the posterior basal one, which are normally the most challenging ones. And if needed, the technique can be suitable in early surgery before ventricular and organ failures, because we don't need to deal with the frail necrotic tissue. And the last thing is that it can be a first-line approach, and if failing, it can be quickly repeated, adding a second or third patch, or integrated in a hybrid strategy. Thank you.
Thank you very much. Any question from the audience? Yeah.
I was curious about the one failure. Was it the only apical VSD, or was one of the posterior basal ones?
No, actually, it was another posterior basal one. There was probably a second It was probably a multiple VSD, but we couldn't see the second one because it was a tiny one. And after the repair in the second postoperative day, it became larger and more like hemodynamic affecting. So we decided to wait because it was not that hemodynamically significantly. And then we repaired it with an hybrid closure. Thank you.
One question.
Sure.
How big was the size? I mean, the
Yes.
Oversizing?
Yeah, I didn't talk a lot about this because the time was very short, but we normally suggest to do them as large as we can, so normally doubling the
size of the
diameter
hole.
of the VSD, but the mean size is around like 35-40 millimeters, so it's pretty big, but there is no problem with the tricuspid and mitral valve apparatus because we come from the top and not from the bottom, so there is very low let's say, risk to interact with the valves. Thank you.
Thank you. Thank you very much.
Oh, and you're back?
Yeah, one more.
Dr. Comencini? Comencini.
That's my last presentation. And this is a study through which we looked at the economic evaluation of endoscopic versus open vein harvesting at our center over our experience of 12 years. We will briefly mention the differences in our outcomes, but the main focus will be on the costs. Vein harvesting techniques, they play a crucial role in CABG operation. Traditionally, the open vein harvesting has been associated with higher rates of complications such as leg wound infection and higher hospital stay. And EVH was introduced as a less invasive alternative. There's been ongoing debate about clinical outcomes and also cost effectiveness of this technique, and we wanted to look at our experience at our hospital. Again, a retrospective analysis with propensity score matching, and all the patients operated on between 2007 and 2019 were included. Our initial cohort consisted of almost 11,000 patients, with the majority of the patients having EVH. The final groups after propensity score matching were almost 3,000, and each group, again, well-matched groups without any significant differences in the preoperative characteristics. In terms of in-hospital outcomes, our open vein harvesting was associated with higher rates of leg wound infection, and also the open vein harvesting group was associated with longer length of hospital stay, 10.7 days versus 8.4 days for the EVH group. We then we did the costing, and these are the key components that we considered in our analysis. And when we evaluated the economic outcomes, these are the results. Over the 12-year period, EVH was almost £3 million less expensive than the EVH, and the difference was primarily driven not necessarily by the wound infection rates and the treatment costs involved, but rather it was because of the reduced length of hospital stay in these patients. So to conclude, our study demonstrated that endoscopic vein harvesting offers superior clinical outcomes compared to open vein harvesting, and in addition to that, although the initial cost might be higher, in the long term, it has a benefit in terms of economic advantage. Thank you.
I think what is very important before doing cost effectiveness on short term is to look at the long term, because as you know in Excel we have looked at that, and of course it's that was not randomized, that was the local practice, but basically the technique was negative in the long term in maize. So that's a comment. Now I have a question for you, a simple one. From all these data, how much has been published?
I'll just make a comment because we did look at our long-term outcomes in this cohort of patients, and we presented it at another meeting, and we did show no difference, again, in our experience. In terms of publication, we are starting to write them up, and we'll be starting to submit them.
So I'm very impressed because that's the 5th talk this afternoon. I mean, I know what it is. You could be confused about all this talk. The question I have is that I have the impression that you have wonderful material. I mean, one institution, so long follow-up, a good database, and so. But I think that in terms of statistics, there is a possibility to upgrade what you do. For instance, you know, people are now seriously talking about the competing risk, for instance. That's one thing. The perception of the patient versus the perception of the doctors. They don't care about death. They are not long any. That's a family which it's sad for the family, but not for themselves that they are dead body. And they're concerned by stroke and myocardial infarction. And then in terms of statistics, I think that you could have more probabilistic formula to look at the future and make prediction and test model that exist in the literature. You could go, you know, all these composite endpoint, which is different now. Win ratio, for instance, would be interesting. Where do you win and where you lose? Because that's a little bit what you see in revascularization. You can lose initially on stroke and late win on revascularization. But it's very impressive what you do and the database. It's a gold mine, gold mine.
Thanks a lot.
The next speaker is Dr. Hamann.
Ladies and gentlemen, thank you for the privilege of presenting. My paper is a simple operational type paper in which I wanted to look at the effect of championing multiple arterial grafting. I have no conflicts to report, and MAGA really reflects an incidental stealing of a logo. This is multiple arterial grafting aspirations. The basic story is this. I left my home institution, Baylor, and went to Beaumont, where I was essentially on sabbatical. I worked for 2 years, and we improved our arterial revascularization to about 60%. I came home, and we were still at home at 5%, which was embarrassing, I thought. I think we can agree arteries are better conduits for ischemia. There's numerous papers. Arterial harvest can be problematic. We've gone over that numerous times. And vein harvest can be convenient, effective, and easy to do. So, if number 1 is true, we should aim for this. If number 2 is true, those problematic harvests should be avoided. And if 3 is true, then we have a formidable contest against vein bypass. If all are true, then we really need to hone our arterial harvesting techniques. This is a simple slide. It's really the results slide. But it just reminds me to show that we have a good program and robust, mature, academic downtown. But CABG is not the focus. We do LVADs, transplants, valves, minimally invasive valves, all sorts of things. The quality was good. For our ISO-CAB mortality MACE, we were 3 stars, 9 out of 10 at times. And our volume was a little bit soft. Lima was used in 99.3%. This is all just to say we did a pretty good job. And so I wanted to know, like, well, why are we still at such a low rate when it's obvious and clear to most dedicated coronary surgeons? So I thought I'd build this data set, where I viewed 4.5 years worth of data, and I referred to Dr. Sabik's paper where he talked about octogenarians, heart failure, and I thought, well, these patients should probably be excluded. That's not a very good denominator. And as with all good papers, I wanted to look at the two differences. You'll see half the patients, I'm sorry, 2/3 of the patients were in the first period when I wasn't there championing, and 1/3 were after I came back home. In the lounge, most good papers come from the lounge, and I discovered that most people didn't agree with Sabik, and there was quite a lot of discussion when he wrote his paper published in the Annals last year. And we used much more stringent criteria. And this illustrates that when you excluded those patients in our denominator using the Sabik criteria, it was about 70% of patients were indicated for multiple arterial grafting. But if you use the commonly employed bantered, if you will, surgeon's criterion, it excluded over 70%, so our denominator was about 35%. Now, some of these were not included in Sabik, specifically HOMO2, not included mantle radiation, not included cirrhosis, et cetera. And so that brings me to the gap slide. So the goal should be 75% or 70% if you're using Sabik's criteria, or about 35% using our criteria. Here is the results slide. This is the gap, and this is the problem, I think. If you'll focus on this first one, using BEMA, we went from only 6.8% before champion to 19%. And I'll describe what I mean by championing here in a minute. And if you looked at multiple arterial grafts, then we went from 8% to 24%. I think that's a poor showing. And so what I want to say with all of these things is that through championing, we could improve, but not very much, the use of arterial grafting. The champion's charge, and I was the champion, only 75% of my cases were BEMAs or multiple arterial grafts. And so there were some other issues. When I investigated my cases, I found there were a lot of things that are not well recorded in the STS data set. Consequently, I think the attainable goal in a robust surgeon or a robust urban type coronary practice is probably 75% of 75% using our current STS data set tools, which supports guidance idea that this is not a very good quality metric to set at 100%. And that's the purpose of my paper. The goal with current data, it's eminently attainable. This admonition, we only accounted for 1/3 of the cabbage cases. And the champion, me, shows that there remains a lot of danger in about 1/4 of the cases that remain. And so multiple arterial grafting and cabbage should be the default, and it should be structured, and our recommendation is parallel to concurrent Lima employment. We do recommend a programmatic champion. A visiting professor, John Puskas, came to visit us during this time. Structured notes consultations so that you specifically report why you're not using the second mammary or the radial artery. And lastly, measuring everything and reporting it semi-publicly in your surgical meetings. Thank you.
Just one quick question. Thank you very much.
I had one comment.
Oh, sorry.
Yeah, so we actually, I think this highlights that when the ACCHA revascularization guidelines came out, why the surgical communities didn't support the guidelines, because there wasn't surgeon readiness You're a champion, I've become a champion of it, and even when we're trying to improve the quality of our own institutions, I saw the same thing, double, but that's double from small.
Right.
So and we're one part of the whole practice. So trying to understand why the surgical societies dropped the guidelines is perfectly captured in your paper, and I think that will help the surgical society buy into the guidelines again.
Yes. Thank you.
All right, so Dr. Scarpanti. I mispronounced it, please.
No worries, it's perfect. Thank you. Thank you, moderators. Thank you, everyone. And today I'm going to talk about the prognostic impact of prior PCI on the clinical outcomes of patients undergoing CABG from our institution. No disclosures. So, as we all know, PCI is the most used treatment for coronary artery disease, especially in the acute setting. But also, at the same time, literature reports that about 30% of patients who undergo CABG have had prior PCI in their lifetime. However, the impact of this PCI, but especially the number of stents and the time frame between the PCI and CABG on the outcomes of subsequent surgery is still debated. So we analyzed 3,916 patients enrolled between 2006 and 2017 who had multivessel coronary disease and underwent isolated CABG at our institution. By school, we do LIMA on LAD and sequential vein on all the other targets. Out of all these patients, 498, meaning 12.7%, had undergone prior PCI before surgery. We linked them to the national healthcare system to have a 100% complete follow-up for long-term mortality and MACE. We excluded from this population patients who underwent emergency CABG due to failure of PCI. So we can see, yes, you can see that the PCI population of patients is statistically younger, with 66 years old versus 69 years of age. They were less likely to have unstable angina or any type of NSTEMI, most likely because those patients who have had NSTEMI or some acute coronary syndrome without ST elevation with triple vessel disease went straight to surgery and not angioplasty. And as one may expect, about twice the amount of patients in the PCI groups were on dual antiplatelet therapy. At the same time, from the intraoperative data, meaning cardiopulmonary bypass time and cross-clamp times, as well as the number of distal anastomosis, there appears no increase in technical difficulty and the number of targets revascularized. These are the postoperative variables, and we can see that in a center where we do routinely platelet function testing as a routine, there's no difference in blood loss and transfusion between the two groups. At the same time, we have no difference in perioperative myocardial infarction and in hospital mortality. We can see a statistical difference in acute kidney injury, but this was most likely attributable to the fact that the no PCI patients were older and possibly with a higher frailty index. We can see here the long-term follow-up in terms of freedom from MACE in the PCI population in red and the no PCI population in blue, and there's absolutely no difference on long-term follow-up over 10 years. And the same is paralleled by long-term cumulative survival. And we can see that the p-value is really not significant on the long run. What are the limitations of this study? So subpopulation analysis is still ongoing at our center, and there's no discrimination between patients who underwent CABG early after PCI and those who've had it years after the percutaneous intervention. And also further analysis should include the number of stents placed and the amount of coronaries that were treated with angioplasty. So in our conclusion, previous PCI did not affect the following short-term outcomes in terms of completeness of revascularization, the risk of bleeding, and preoperative MI. As far as long-term outcomes, there is no statistical difference in terms of mortality and MACE. But of course, further multicenter studies should be performed. Thank you.
You are a surgeon?
I am a resident, a last-year resident.
So that's interesting because there was a time where it was said PCI really disturbed the job of the surgeon. I mean, you do a full metal jacket and the surgeon cannot put any more his bypass. That's what is in my mind. So I'm very surprised by your result. I didn't follow the field for some times, but it is quite amazing. I think what is going to change in the near future, of course, there will be more prevention and going for the young patient. You know, the old patient, you have to block the calcium, you have to bypass the calcium, and so. But I think what is changing quite quickly now is that the interventional cardiologists try to avoid the metal in the coronary artery. That's what going. It was a nice solution for 20, 25 years. But now what is interesting is that this remodeling, we were looking at this vessel for endarterectomy. That's the type of patient that the people do now with drug-coating balloon, and going more than one times, you know, the dentist approach. I mean, you try to keep the plaque accessible to the drug, because that's the point. When you cage the thing, it's finished. I mean, 300 years later, the anatomopathologist will find, why so much metal in the coronary artery? So I think that that's a big change, but I'm very impressed by your data. What about this previous story of the interventional cardiologist is destroying the landing zone for the bypass of the surgeon?
In our experience, we have very experienced coronary surgeons, amongst which is Dr. Menicanti, and we don't stray away from distal bypasses or even opening and eradicating stents if it's a potentially good target for the anastomosis. So luckily, we're in a center where we don't stray away from these patients, and we try to achieve as complete of a revascularization as possible, even targeting prior stented lesions or targeting coronaries with endarterectomy when necessary.
So next speaker is Dr. Oda from Tokyo.
Good evening, everyone. It's a great honor to be here and a pleasure to present today. I will begin my presentation. Coronary steal syndrome, CSS, is a critical concern in CABG with retired anastomosis for dialysis patients. A meta-analysis reported asymptomatic CSS occurs in 6.46% of hemodialysis patients following CABG with retired anastomosis. Previous studies suggest that left subclavian artery LSCA stenosis influences the occurrence of CSS. While the use of LITA is typically avoided in cases of severe LSCA stenosis, moderate stenosis does not necessarily preclude its use. This study evaluates the impact of moderate LSCA stenosis on long-term outcomes of hemodialysis patients undergoing CABG with retired anastomosis. This study included 1,744 patients who underwent primary isolated CABG between 2009 and 2022 at Juntendo University Hospital. The analysis focused on 106 hemodialysis patients with left upper limb arteriovenous fistula who underwent retired anastomosis and had preoperative contrast-enhanced CT. Patients with a LSCA stenosis rate of 50% or higher were classified into the stenosis group. Propensity score matching was applied for covariate adjustment. The primary endpoint was all-cause mortality, and secondary endpoint were cardiac death and MACE. LSCA stenosis was evaluated using preoperative contrast-enhanced CT. Patients were classified into the stenosis group if the ratio 1 minus contrast area divided by vessel cross-sectional area exceeded 0.5. This graph illustrated the distribution of LSCA stenosis. The stenosis rate between 0% and 78%. No significant differences were observed in patient backgrounds between the two groups. After matching, the groups became more comparable. No significant differences were observed in these operative data. Early outcomes show a higher difference in incidence of arrhythmia in the stenosis group. Primary endpoints. Kaplan-Meier curves are presented, with the blue line representing this stenosis group. In the stenosis group, mortality was higher in both original and matched cohorts. Multivariable analysis identified age, peripheral artery disease, and SCA stenosis significant risk factor for mortality. Secondary endpoints. Cardiac deaths were more frequent in the stenosis group in the original cohort. The incidence of MACE was higher in the stenosis group in both cohorts. In conclusion, CABZ with retired anastomosis may not be a safe long-term option for hemodialysis patients with moderate LSCA stenosis. Further research is needed to develop optimal strategies for managing LSCA stenosis in these patients to improve long-term outcomes. Thank you for your attention.
Any questions?
So thank you for your presentation, and I'm Dr. Yang Yi from Shanghai, China. So I have a question. So did you measure the flow with TTFM for two groups? Is there any difference or something like that? Yeah, thank you.
Thank you for your questions. That's right.
It's okay. You can take your time.
Okay. No significant differences in TTFM value in cohort, and rather in the stenosis group, more higher in this line is TTFM flow. Stenosis group is 35, but non-stenosis groups so 26. So no significant difference in this value, but higher in stenosis group.
Thank you.
Okay.
One question. So according to your data, so you said that the long-term data is with the stenosis group is not good. So which means after this study, have you changed the strategy, like not to use the shunt side for the like a left side shunt? Then you can use a Rita instead of a Lita. What do you think?
I think we use light ITA to LED anastomosis.
Okay, I see. Thank you very much.
All right, next we have Dr. Hu. You?
Good afternoon, ladies and gentlemen. I'm Dr. Hu Junlong from Fuwai Central China Cardiovascular Hospital. And, here is an area view of my hospital, located in an old and fashionable city, Zhengzhou, in central China, and performed more than 7,000 cardiovascular surgery cases last year. Its volume ranked top 4 in China. There is no conflict of interest to declare. Background: post-operative atrial fibrillation is one of the most common complications occurring after cardiac surgery. And posterior fenestration is considered a method to reduce the risk of AF, inasmuch as it allows drainage of pericardial effusions into left pleural space. Our study aims to evaluate the necessity and the effectiveness of this technique in our real-world practice. Method. So this is a single-center retrospective study from December 2017 to 2023, a total of 4,700 cases of CABG performed in our center. And the 500 patients who underwent off-pump CABG and posterior pericardioectomy were selected and assigned to Group A, and through propensity score matching, another 500 patients from the same period who underwent off-pump CABG. Without this technique were selected and assigned to Group B. Group A harvested lemma with left pleural space open, whereas Group B kept it intact. Group A placed 2 chest tubes at the end of surgery. One is in the left pleural cavity, and the other in the anterior mediastinum. Whereas Group B placed 2 chest tubes, one in the anterior mediastinum, and the other in the pericardium. The chest tubes were removed when the volume of daily drainage was less than 100 milliliters. The method, all patients had a 5-day continuously electrocardiography monitoring, and arrhythmia more than 20 minutes in this duration were considered clinically significant. All patients underwent echocardiography before operation, after the operation on day 1 before discharge, and on day 30 post-discharge. A grading of pleural effusion using the same criteria: small, moderate, large, and very large. All related data were collected and analyzed. So here is the video. It's very simple. When we do this, we'll disconnect the ventilation first, then make a T-shaped incision posterior to a phrenic nerve. When we finish this, we will flush with cold water and examine if there is any bleeding, then connect the ventilation. We can do this procedure in 1 minute. So results, there was no difference in baseline between the two groups. There were no difference in operative parameters such as operation time, number of grafts. There were no significant difference between the two groups in terms of postoperative pulmonary function, duration of ventilation, ICU stay, and the hospital stay. There was a significant decrease in the incidence of cardiac tamponade in Group A than in Group B. There was a significant decrease in the incidence of post-operative atrial fibrillation in Group A than Group B. The early pericardial effusion, greater than moderate volume, and the late pericardial effusion were significantly less frequent in Group A. So conclusion, the pericardial fenestration technique in CABG surgery is simple, safe, effective, and necessary. Thanks for your attention.
What about medications? Post-operative medications, were they different between groups? I may have missed that. Amiodarone or metoprolol prophylactic? No.
Sorry, beg your pardon?
Were there any difference in the atrial fibrillation medications that were administered in the groups? Like metoprolol, a beta blocker?
Yeah, we use the same secondary ventilation, beta blocker, or the same medication.
So everybody got beta blocker?
Yeah.
Thanks.
Thank you.
Once. I may have missed, but what's the rate of the off-pump technique in this study? We presented, I may have missed, but.
So there are so many factors that may cause the atrial fibrillation. So to eliminate the other factors such as CBB, the inflammatory, so I choose the off-pump cases.
Oh, those are all off-pump?
All off-pump.
All off-pump,
Okay,
yeah.
thank you.
Thank you. Thank you so much.
Last one?
Yeah. So last presentation is Dr. Zhu.
That was a good question. Yeah, that was a good question.
Thank ICC for the opportunity to present design and rationale of the trial favor for COVAS, quantitative flow ratio guided revascularization strategy for patients undergoing primary valve surgery with a concomitant coronary artery disease. As we know, concomitant coronary disease is very frequent, observed in patients with valvular heart disease, especially in older population. In clinical practice, there are 15 to 20% patients receiving combined valve surgery and CABG. It also recommended by guideline the coronary artery disease is necessary to screen in the population over 50 years old. The current guideline recommend combined valve and CABG surgery in left main disease over 50% or major coronary branch over 70% with two or one type class 1 or class 2 recommendation, but all evidence level is C, which is lack of randomized trial to support. So in the real world, the STS database showed the combined valve surgery and the CABG has more mortality and morbidity. It is 2 to 4 times than isolated the valve surgery. So we are asking, are these combined CABG necessary? The FFR is recommended for PCI, but it's not used or not very solidly used in CABG. The QFR is a novel approach of computing FFR. It has been used and in PCI and recommended as class 1 in 2024 European guideline. So we are going to do CABG strategy guidance with QFR compared to angiogram strategy. We did a pilot study which composed of 69 QFR guided and 119 angio guided. The 3-year outcome was of MACE was low in QFR guided. So this is a design of the Favor 4 trial. We randomized the patient to 2 arms, QFR guided, which patient receive CABG only the target vessel of QFR less than 0.8, and angiogram guided CABG for all vessel stenosis over 50%. So we have 2 core primary outcomes. So the 5-point MACE for 30 days and late primary outcome 6 MACE for 1 year. This is a statistical hypothesis. So the outcome is a superiority analysis, and 1 year outcome is non-inferior testing. So we have 12 hospitals participating in this trial, and the first patient was enrolled in August 2019 and finished the enrollment August this year. Totally 10,269 patients of primary valve surgery were screened, and 11% patients had coronary artery disease, and finally 792 patients randomized. So we will report the primary and early primary outcome and the late outcome next year. Thank you for the attention.
We have a little bit time.
Yes, sir.
Yeah. So I think it's a very important study, but it comes at a difficult time because, I was co-author of the Favor China with Van Tu and Shubo. That was demonstrating QFR is better than visual. That's it.
Yes.
Now we have recently a study called Favor Europe, which shows that the FFR is superior to QFR. They were going for a non-inferiority, but they end up with a superiority of the FFR on the QFR. So that's already making our job a little bit more difficult. And then what makes the things even more complicated is that there is a publication in The Lancet just a few days ago by Kedi, who has randomized FFR valve and surgery, PCI and TAVR, and the study was interrupted because the TAVR plus PCI was far more superior in terms of mortality and so. So it's the great asset of Japan is that they are able to do study in a zip. We take 4 years to do that. They do that in 1 year. So it's coming. It will be part of the whole game, but I think that it will be something difficult to establish between these different options. I don't know what is your feeling on that.
I think the population is different between Asia and Western country. We see more rheumatic and congenital valve surgery. And also the disease type of the valve is mitral regurgitation and aortic regurgitation in China than in Western country. So probably we have a subgroup of patients need different strategy.
I was underestimate that with my Western Eurocentric vision. Yeah, that's a good point.
Thank you, Dr. Solis.
Are you expecting to see less need for revascularization with the QFFR?
Yes, we did found after the QFR guidance, 48% of patients had less grafts than before the QFR analysis.
Yeah, the valve CABG patients are the sickest patients, right? And so you just need enough revascularization to protect the myocardium.
Yes.
But nothing more.
Yeah, but the advantage of combined surgery is less ischemic event, but increase the time of pump and arterial cross clamping, increase the injury of the myocardium. Also increase the risk of renal failure and stroke. So we don't know.
Whatever we can do to move the needle is wonderful. So congratulations.
Thank you.
Thank you. Thank you for this fantastic session. Yeah, close it down for today. All right, thank you so much.
Yeah, thank you very much.